Hello everyone, it's Claire Snowden here. Welcome to the webinar today for the Trial Conduct Working Group. We have Chris Rogers with us. Chris is very familiar with the webinar. She's part of the Trial Conduct Working Group team. She's co-chair with me, so it's really good to have her with us. Just to give you a little bit of background to Chris, she's a statistician. She's a co-director of the Clinical Trials and Evaluation Unit at Bristol, and where she's there, she leads a number of the NIH-funded multi-centre trials that are running there to evaluate care in hospital settings. She's also, as I said, the co-chair with me, so you know, it's really nice to have another member of the working group with us. Chris is going to talk, as you can see, about audio recording recruitment consultations, and I'm really interested to hear this, as I tried to do this for a qualitative study embedded in a trial around at least 20 years ago, and it seemed almost impossible then. It was really difficult, and we had to abandon our approach. So I'm very, very interested to hear what Chris says about running this exploratory study now in the current climate, and the work they did to look at the effect in 2 RCTs on randomisation rates. I'm going to pass over to Chris in a moment, but can I just ask, as you're listening, you may think of some interesting questions. You can either put them in the Q&A box, or you can save them, and if you have a microphone, you'll be able to speak later on and flag that up. So you could either flag up that you do want to ask a question, or you could just raise your hand later on. If you can use the Q&A box rather than the chat box, that's really helpful because they only have to look in one place for questions and I'm less likely to miss everyone. So Chris might talk for, say, 20-25 minutes, and then we'll turn to you all for a good discussion, I hope. Thank you, Chris.
Okay, thank you very much, Claire, and particularly thank you because I know you're doing this while you're on holiday this week. So welcome everyone to this webinar. As Claire said, I'll just try and move to the first slide. Now, why is it stopped? Hang on. I got this to work earlier. There we go, sorry. As Claire said, I'm going to be talking to you this morning about audio recording recruitment consultations and an exploratory study that we've done in 2 trials that we've been running here in Bristol, and particularly looking at the impact on randomisation rates. So these are 2 NIHR-funded trials in surgery. The first is the bi-band sleeve study. Bi-band sleeve is comparing gastric bypass, gastric banding, and sleeve gastrectomy surgery. It started quite a while ago now, back in November 2012. Has a primary outcome of weight and quality of life at 3 years. And this was the trial that everybody said couldn't be done. So I'll show you in a minute how we've got on with that one. But you can see that it's 3 very different surgical procedures that are being compared. The second trial that we also have audio recording as part of the trial that we've looked at is the Violet study. And that's comparing video-assisted thoracoscopic lobectomy versus conventional open lobectomy for lung cancer, early stage lung cancer. So that's basically a large incision versus a very small, what they call a VATS incision for patients with early stage lung cancer. And the primary outcome for that trial is physical function as measured by the QLQC30 at 5 weeks. So both of these trials are looking at, as I said, very different interventions in terms of their surgery, and they were both expected to be very challenging in terms of recruitment. The reason being that there was a strong feeling that there would be very strong preferences either amongst clinicians and or potential participants that would make the recruitment to the trial difficult. And as I said, bi-band sleeve in particular on the back was conceived on the back of a systematic review, and the conclusion from that systematic review was that it would be the trial that couldn't be done because of such strong views about the 3 different interventions amongst patients and clinicians. So with this in mind, when both of the studies were designed, we have built into the trials the Quintet qualitative recruitment intervention and integrated that into the two studies with a view that this would help us overcome the perceived challenges that we expected to face. So what does the QRI involve? And as Claire said, I'm a statistician by background, so I can tell you a little bit about the QRI, but it's clearly not my area of expertise. But essentially it's running in two phases. The first phase is about understanding recruitment, and the second about giving feedback to the study team and the recruiters. Looking first at the first phase, what does that involve? Well, they work really closely, the QRI team work really closely with the teams on the ground in the sites and with the staff in the trials units to understand the patient pathway, so how the patients get from the point of referral through their pathway through to eligibility, assessment for recruitment, and then on to receive their intervention. So they work very closely with everybody involved to really understand and unpick that process. And alongside that, as part of that process, they conduct in-depth interviews, and those are interviews with the people actually at the trials unit, so the research nurses, the surgeons, everyone essentially that's involved in that pathway. And they also conduct some interviews with participants that are willing to have in-depth interviews with the qualitative researchers. But really the key element of the QRI, and the element that I'm focusing on today, is the audio recording of the recruitment appointments. And the sites are all told about this element of the study at the site's initiations and explained how to use the recorders, etc. And we ask for recordings to be done of everybody that's involved in that pathway and everybody that's involved in consultations relating to recruitment into the trial. So not just the surgeon who will be involved in that final discussion, but they do get audio recordings of others involved as well, although the work that I've focused on is looking particularly at the surgeon element of it today. So in addition to that, they input into review of study documentation, and it's been very insightful having the QRI input into that aspect of a trial. I mean, we've learned over that time that patients typically don't like to be studied to be referred to as a trial. They feel it's like an experiment, and they like study is a better word. So now we tend not to use the word trial, but use the word study for all of the studies that we do. And they've really helped in terms of explaining randomization and moving away from the concept of tossing coins, gambling, etc. So we have a lot of input into that side of the study as well. And in addition to that, there's observations at investigator meetings. So in collecting all of that information together and really understanding about the recruitment pathway and the recruitment process, then the other key element that the team do is to provide feedback. And this feedback takes two forms. So it's group feedback to everybody at a site that might be involved in the whole recruitment pathway and procedures, but it's also confidential individual feedback that they give to individual recruiters. And something that we found particularly useful in the two studies, they've also produced top tips documents to really guide people on how best to approach the consultation in relation to the trial. So to introduce the study early, have a sort of a beginning and a middle and an end and so on, and particularly to challenge preferences, but to also present everything in a balanced way. Okay, so that's a very brief overview of the sort of thing that the QRI involves. So just looking a little bit further at the pathway, the pathway at the top of the slide is the pathway that we have in the trial where we've got a study without the QRI embedded into it. So patients are referred for surgery. The team will identify whether they're eligible or potentially eligible for the study. They'll be either sent or given an information leaflet about the trial, depending on how things are organised in the site. They're then typically approached in the clinic, and if they agree, after that, they're consented to the study. But when we have the trials with the QRI embedded in them, then we've got these two additional elements. The first is that having identified an eligible or a potentially eligible patient, they are first given information about the QRI intervention, either before or at the same time as they're given information about the trial. Okay, so they get additional information, and then when they come to the clinic, they are first asked whether they will consent to their consultations being audio recorded before there's any discussion about the trial itself. What I should say is that if a patient declines to take part in the audio recording, they can still take part in the trial because they are not, one does not depend on the other, but we ask them about consent to both. And what I'm going to show you today is the results as to what happens for patients who have consented to audio recording and those who haven't. Okay, so just briefly, that's the patient pathway. So looking at some of the results for the two trials, and you can see here on the left, I have some data for the Byband sleeve study, and on the right, some data for the Violet trial. Okay, so at the time these data were pulled together, we'd had just over 3,300 referrals to Byband sleeve, of which 72% of the patients were considered to be eligible for the trial. Of those eligible patients, 88% were sent information about the QRI and were asked whether or not they would be willing to be audio recorded. And 93% were sent information about the trial and asked whether they would be willing to take part in the trial overall. And in terms of consent rates, you can see that of those that were approached and asked, 79% agreed to being audio recorded, and 35% overall consented to the trial. Okay, and these data came from 11 centres and 46 surgeons, and at the point the data were collated, the study had been recruiting for a total of 54 months. If we then look at Violet on the right-hand side of the slide, you can see that we had 850 referrals and a slightly lower eligibility rate at just 45%. In terms of patients being sent information and asked about audio recording, it was slightly lower at 78%, but the proportion of patients who were approached about the trial was pretty much the same at 92% compared to Byband sleeve at 93%. Interestingly, where patients were invited to take part in the audio recording element of the study, the consent rate was exactly the same in both trials, so 79% again consented to audio recording. And what we see with Violet compared to Byband sleeve is that the consent rate to the trial was quite a bit higher overall at 63%. And at the point these data were collated, we were recruiting in 5 centres for Violet. There were 14 surgeons involved, and they'd been recruiting for 22 months. So having seen these patterns, we then tried to unpick the data a little bit further. But just before I do that, just to show you that these are the data overall and how we were doing at that point relative to our target recruitment. So although you can see Byband sleeve is a little bit below the numbers that we would like at that time, it's still, we were very comfortable with where we'd got to, given that we knew Byban sleeve was going to be such a difficult trial. What we had anticipated and what we'd aimed for was for there to be a sort of 45% recruitment rate once patients had, or once the teams had been trained and had the feedback from the QRI, etc. That's what we kind of was at, sort of what we were aiming for, and unfortunately we weren't seeing that the teams were getting quite to that level. But things, as you can see, were going very well for Violet, and we were by and large just recruiting a little bit above the target for the Violet study. So then looking at the audio recording in a little bit more detail, and here you can see the data for the 11 sites for Byban sleeve to the left of the green dotted line, and the 5 sites for Violet trial to the right of the green dotted line. And the heights of the bars represent the proportion of patients at each of the sites that were approached to take part in the audio recording element of the study. Okay, and then the proportion in blue of those bars are the proportion that consented and agreed to audio recording. So if you look at the first site for Byban sleeve, for example, there was actually 99% of patients who asked about audio recording, and only a very, very small proportion actually declined. So 98% actually consented to the audio recording. Whereas the approach rate was somewhat lower for site 3, Byban sleeve site 3. And again, they also had proportionally fewer patients who consented to audio recording. Looking at the Violet sites, you'll see there's one site, site number 3, where they really weren't engaged in the audio recording element of the trial at all. They were very concerned around the pathway and about whether patients were even aware that they had lung cancer at the point we wanted to begin the audio recordings, and they really didn't engage in that site with the audio recording element of the study. But if we exclude that third Violet site, then the range across all of the sites for the 2 studies for approach about audio recording was from 71% to 99%, and in terms of consent, it ranged from 70% to 98%. Okay. Looking then at the trial, and we have the same pattern again, so the height of the bars are the proportions that were approached about the trial, and the bars in green are the proportion that then actually went on and consented to the trial. Okay, and you can see that the approach rate is also quite low for the 9th centre for Byban sleeve, and they also had a lower proportion of approach for the audio recording. Site 2 is also a little lower in terms of the proportions that were approached about the trial, although they had a higher approach for the audio recording element. And there's not much variation across the Violet sites in terms of the proportions of patients that were approached. And obviously the highest consent rate we can see is in the 5th site for Violet. So in terms of approach to the trial, that ranged across all of the sites from 73% to 100% in the 3rd Violet site, and the consent rate ranged from 24% to 82%. So I then brought all of those together, and here on this slide you can see on the left we have Byban sleeve, and on the right the Violet study, and the first bar in each panel is the proportions of patients who declined to be audio recorded, and in the right the proportions, the patients who consented to be audio recorded. And you can see in terms of the approach overall, both the bars are pretty much the same height for where there was no consent to audio recording and consent to audio recording. So that's saying that there wasn't a differential approach of the patients for the trial, depending on the patient's decision with regard to audio recording. But we see that the consent rate to the trial in both studies is significantly higher amongst the patients who consented to audio recording compared to those who didn't. Okay, so the left bars are those where there was no audio recording, and you see we have a very low consent rate to the trial, whereas the right-hand bars is where we did have consent to audio recording and a much higher consent rate to the trial, and that pattern was apparent in both of the studies. Okay. I was also interested in whether there were changes over time. So as the sites got used to the study, as they received feedback from the QRI team, as sort of everything embedded in the site, whether there were any changes in the rates of consent, either to audio recording and to the trial. And here you can see the results in terms of consent to the trial by era of recruitment. And the top panel for the patients who did not consent to audio recording, and in the bottom panel where there was consent to audio recording. Again, we've got Byron Sleeve on the left and Violet on the right. And I think generally our sort of interpretation of that was there wasn't anything particularly striking, at least from the descriptive data, suggesting that there had been a major change over time. So there was nothing that particularly stuck out there. There is a bit of dip in Byband Sleeve in terms of the proportions around 25 to 30 months. I think that was at the point at which we were bringing on some additional sites. But there wasn't anything other than that that particularly stood out. So then what I tried to do was to bring all of that information together and see whether we could actually quantify the effect and the impact of the audio recording on the consent rate to the trial. So what we did was what we call logistic regression. So our outcome for the analysis was consent to the trial or not. And we looked at a range of factors. So I looked particularly about the consent to audio recording. I had an indicator for the two different trials and an indicator for the era of recruitment. And what we get in terms of answers is an odds ratio, looking at the odds of consent to consent to the trial. And you can see the black vertical line corresponds to there being no difference, basically no effect. The blue dots are the point estimates and the red lines are the 95% confidence intervals. So essentially what we found from bringing all of this together, and we also took account of the different surgeons involved in the consenting consultations themselves, and we found that patients who consented to audio recording, as we'd seen from the descriptive data, were actually more than 6 times more likely to consent to the trial than those who did not consent to audio recording. So we're actually able to quantify that. We found that the consent rates did vary between the two studies and that they were significantly higher in Violet compared to BBS, again, which made sense from the descriptive data that we looked at. And when we looked specifically at the era of recruitment, once we'd taken these other factors into account as well, we found that there was really no significant effect of era at all, that there really wasn't anything going on. We didn't see any obvious patterns over time. Okay. So in summary, the majority of patients who were asked to consent to audio recording in both of these studies. And we found that consent to audio recording was a strong predictor of a patient's willingness to be randomized. On average, they were more than 6 times more likely to consent to the trial if they'd been willing to be recorded. And this effect remained after we had taken account of era and of surgeon. The reasons for patients consenting or declining randomization are multifactorial. In both of these trials, the recruitment pathway was complex and involved discussions with several healthcare professionals, all of whom could contribute to a patient's decision-making in terms of whether they decided to take part or not. And there are many other potential factors that we haven't considered thus far, in particular the timing of the QRI feedback and the surgeon's awareness of whether they're being recorded or not and what impact that might have. In addition, we've got some limitations, in particular the characteristics of the patients who don't join the trial are not captured. So we're unable to determine if those who decline audio recording and or decline the trial are different or similar in terms of their characteristics to those who consent, because we only have data characterizing the patients on those that consent to the trial. So that's a limitation. And we've been unable to unpick whether a willingness to be audio recorded is a proxy for willingness to be randomized per se, or whether it's a willingness to be randomized given the QRI input into the recruitment process. I think that's about me done, so I just need to acknowledge my colleagues and everybody who's worked on both of these trials, so the Hub Network for Trials Methodology Research, in particular the Conduct Hub, and most importantly the research teams, the surgeons and the nurses at the study centres and the participants, because without all of them none of this would have been possible. And thank you all very much for listening.
Thank you very much, Chris. That's really interesting. You can see there are lots of rich themes for further mining there, I think. We've got an interesting question from Fran Sherratt. I don't know whether you can see it, Chris. If you can't, I'll read it out, and I'll read that for anyone anyway. She's asking about the challenges sites not engaging in consultation recordings. So she says she wonders if Chris has experience of sites refusing to participate in consultation recordings, and if so, how you responded, and if you've any tips for less engaged sites. And we certainly saw a little bit of that in a couple of your slides.
Yeah, we have got one site in particular that you saw in the Violet trial that wasn't particularly engaged in the audio recording element of the study. I mean, it is difficult. The QRI team and the team as a whole do everything that we can to encourage the sites to take part, because I think what they get out of it is not just feedback on these consultations, but it can help all of their consultations that they might have with their patients, not just in a trial setting, but outside a trial setting as well. So the surgeons who are taking part are really strong advocates for the benefit of what they get out of the QRI intervention. But at the end of the day, some just decline and don't wish to take part, which is sometimes to do with the pathway, and in particular in that Violet site, it was to do with the pathway and what they felt the patients knew at the point at which they wanted to give information to them, and the information had the words lung cancer on it, and they were very concerned about that. But I don't think it's particularly necessarily, it's just the way it is. But we do absolutely everything we can to encourage sites to take part, and the QRI team are very engaged with the centres and will go and give presentations. They always contribute to the site initiation meetings that we have with the centres, so that they can see exactly what they can get out of it. But sometimes it just doesn't happen. Yeah.
So that's an important tip for engaging with sites, that sort of early connection and contact.
Yeah. And if you're going to embed the QRI into a trial, I would really strongly advocate that you work with them really early on, right from the very beginning. It's so much easier, and we worked very hard to integrate everything into the trial processes to make it seamless and not just a bolt-on.
Mm-hmm.
So, for example, the way the audio recordings get to the QRI team are through the trial database. So the sites actually upload their audio recordings to the trial database. They're connected, linked in to the particular participant and surgeon, and then the IT team here do their magic and they automatically get shipped to the QRI team. So that's worked in a really efficient and seamless way that we don't have to send memory sticks in jiffy bags or anything like that. So it's really, really important to engage with them really early on so that you can set things up that are of mutual benefit to both to the trials unit and to the QRI team.
Okay, thanks. So thank you for that question, Fran. I hope that gives you some tips you're thinking of. We have another question from Anne-Marie Swart, and she's asking about lack of time. Does the lack of time affect, presumably for the clinicians, mean that feedback is ineffective or less important?
I'm not sure I understand completely what you mean by lack of time. I mean, I think it is difficult to engage with clinicians in that they are very busy, but there's lots of feedback that the QRI team have done with the sites, and it's not just a one-off. They go regularly and monitor the recruitment and go regularly, and they talk to the clinicians. They both go to the sites and they will do consultations over the phone. So I think the surgeons are busy, but in terms of actually facilitating the audio recordings, it's the research nurses that do that. It's them that set up the audio recorders and deal with all of the work around it. So I'm not sure that lack of time is particularly a barrier. At least, I mean, my QRI colleagues might say differently, but I don't think it's come across to me that it's a particular barrier in terms of lack of time.
Oh, that's helpful. While we wait to see if there's any more questions come in, can I just jump in and ask one? Have you seen this sort of pattern that you talked about here today? Have you seen it in other trials?
I haven't, but I also haven't looked.
Right.
To be fair, we've got another couple of trials that have QRI embedded in them that we're doing here in Bristol, but one, the QRI is only just being embedded now, so we will be able to look at that in due course to see whether we see a similar pattern. And we have one other that's a bit further on that I should look at and see whether the same trend is there. So I've got one other potentially that we could look at, the Romeo trial, that we may have the same pattern, but the other one where we've got QRI, as I say, is only just beginning, so we don't have any of the audio consent data yet to be able to look at that one. Okay.
And also, can you tell us a bit more and maybe expand on what you've told us so far about how you've integrated the QRI into the trials, that integration process?
Yes, thank you, Claire. Well, what we did was right from the very beginning, because Byband Sleeve was the first study that we integrated QRI into a trial, and I can be honest, at that point, I really didn't know anything much about what it involved at all, but I was very mindful that I wanted it all to be joined up. So we've made sure that the consent process, the screening process, so the screening logs that we have for the trial isn't just for the trial, it includes all of the QRI in it. And as I say, we've embedded that into the database. So the trial database is really the engine that delivers the communication between all of the various bits so that the audio recordings can be uploaded, for example, and then the trials team here at the trials unit produces regular reports on numbers of patients that have been consented, numbers that have agreed to audio recording, etc., etc. And those are automatically shipped to the QRI team every week, so they get up-to-date quantitative information on what's happening in the study to help inform their when they're sort of listening to the audio recordings, etc. And they might, similarly, they get information on patients who drop out or crossovers, etc. And will often go and look particularly and listen to audio recordings around those consultations if that happens early on in the process. So we've really integrated the whole lot together to make sure that we're all singing essentially from the same hymn sheet.
Thanks. We've got a question from Alina. She's asking about whether or not you have data for sites that continue to recruit after using the QRI. So she says, do they continue to recruit well after the QRI process, or do you think the Hawthorne effect has a large role? That's quite an interesting question.
Yeah, the two particular studies that we've looked at still have the QRI process in the entire recruitment period. So I can't actually unpick that if we took the QRI away, what would happen? I think that's a very interesting question. And if you were only having the QRI sort of in an internal pilot phase, for example, and you didn't have it afterwards, then you would be able to sort of look at that. But I've not been able to look at that in these trials because both still have the QRI ongoing.
It's quite an interesting idea, though, isn't it? That
yes,
maybe
it is.
Yeah.
And I think, feedback from the surgeons is that the tips that they get in how to present the study in a balanced way, because there's a lot of focus on equipoise and challenging patients' preferences that, they may be genuine, but at least sort of putting maybe the other perspective. And I think, a lot of the clinicians have said they just find that useful. And thinking about things in that way in their routine clinical practice, not just in the trial setting.
Yeah. And can I ask about the negotiations that you did with the clinicians about the recordings and how comfortable they were sort of taking that first step of recording what they had to say and asking their patients? Have you got any feedback for us about that process?
Well, I didn't do any of those negotiations because that was very much down to the QRI team, so I can only talk as an observer in that. But other than to say that the team are really engaging with the clinicians and very much about presenting it in a way that's very supportive and non-threatening, and they really emphasize that the audio recordings are confidential. I should say I've never listened to a single one of them. So those consultations are they are totally confidential to the QRI team, and they use snippets from the consultations for teaching and feedback and so on, but they are totally anonymized, so you would never know who they came from. So I think the way in which it's presented is it's really presented in a non-threatening way, and with the idea that the whole QRI process is supportive and almost something that's an added value within the trial.
Okay, so that's quite an interesting take on the sort of dynamic of setting up a study as well, and feeling what sort of investment the people on the recruitment side might have in a different way. So I know you have your particular work that you're trying to carry out, but there are spin-offs for them about relationships with patients and about their own confidence and getting feedback on their own personal practice as well, which is a very interesting component.
Yes.
Yeah. Okay. Well, we've covered the questions that are in the Q&A. I don't think anyone else is asking anything. Anyone else has their hand up. Chris, is there anything that you want to raise? Anything that's come to mind as you've been talking, or anything you'd like to add?
No, I think I've summarised pretty much everything that we've done so far. I think what we're going to do next is to see whether we can do some work in a trial that doesn't have a QRI to try and unpick some of these elements a little bit more, to see whether, you know, if we just have audio recording and we don't have any actual QRI feedback, do we see similar patterns?
Right.
So just try to unpick it a little bit more, just for understanding purposes.
Okay. Oh, that sounds like a very positive next step. Well, thank you very much, Chris. That was really interesting. Our next seminar, if you're interested in coming along, which I hope you all will, is going to be given by Addy Perkins from the Clinical Trials Unit at the London School of Hygiene and Tropical Medicine. I heard him talk recently, and the paper that he will give is very interesting on emergency trials and some of the ethical issues involved. So that's going to be in June, our June seminar, and that will be Monday the 18th at the usual 12 p.m. So if you come along, that would be great, and you'll probably pick up more details of that as they're circulated. So thanks again, Chris, and thank you everybody for coming along.
Thank you.
Bye.
Bye.